All right. Welcome, Aaron. It's just the two of us. Have I ever told you the story about Socrates? Socrates is would be in Athens. He would always be with students, teaching and things like that. And all he needed was one student to give an entire lecture. So if it's the two of us, that's a quorum. So today, this is the view from outside my house. Last night, so I had to clean off. Actually, I didn't clean off my wife's car, so she may get a little upset. I usually do that, but I was in a hurry. Okay, so today's case, is the door locked? Is this locked? Maybe just leave it open. It probably locks. Oh, okay. It doesn't lock in. So today's case is a 61-year-old man with a 4-day history of ataxia, and he basically has Down syndrome, and he lives in a group home. And the group home, his sister lives in the group home. His sister has Down syndrome, so does he. And they just walk around. They kind of mill about the house by themselves. There are other people in the home, I believe, that also have mental deficiencies. And I think someone just comes there and takes care of these people. So this man, he has no guardian. He and his sister have no guardian. And in fact, the state takes care of him, but nobody really is responsible. So basically, Harford County Public Health takes care of this guy. So he just stopped walking, and normally he walks around. They took him to the ER, and in the ER, he doesn't speak. So he just makes, he sort of functions mentally like a 1-year-old, his brain, but his body, he can walk around, but he cannot take care of himself. He can feed himself, but that's about it. But he does walk around by himself. He wears a diaper, and he just stopped walking, so the caregivers didn't know what to do. So they can't just have this guy just laying in bed. So they just brought him to the ER. So you have any? Good morning. Come in. So do you have any experience with? So this man, you basically have to treat him like a baby. Like have you done much work with children?
Besides having them, no.
Okay. How about you, Megan? Have you ever examined children? Have you ever done much work in children?
How old?
Any child. 0, 1, 2, 3, 10.
Not that young.
Not that young? Okay.
But like 6.
6. So you can talk to a 6-year-old.
Yeah.
So you can ask a 6-year-old questions, but a baby you can't ask questions. So since you guys don't have much experience, I'll just keep talking. So basically, babies, you just have to watch them. So you just have to just sit there. They don't take orders. So you have to sit there and watch them and kind of coax them to walk around the house or walk around, or have mom see what they can do, put them on the table, put them on their belly, see what motor function they have. So that's basically what I had to do with this guy. I just went in there, and I didn't know what to do, because they told me he was paralyzed, but that's all he wouldn't walk. So I kind of just put my hand out, and he grabbed my hand. So I knew he had function of his in his cervical spine, and he could push me away. So he had C7. He could touch his face, so that's at least C5. He could raise his hand over his head, that was at least C5. He's breathing, obviously, so he's above C4. So cervical spine's functioning. As far as his lower legs, he wasn't moving. So I didn't want to. I tried to say, move your leg. I mean, he doesn't respond. He just makes grunting noises. So then I sat him up on the bed, and then I just sort of brought him up to a stand, just myself, and he could stand. Well, that right off the bat, he has a lot of function. And so, if to stand, what's the most critical motor group to stand? Do you remember?
Quads.
Yeah. Be confident. You know this stuff. Quads, right? We go this over and over again. So you need quads to stand. So like, especially in kids, if the kids don't have quads, they can't stand. I mean, that's what you need. So he's got quads, which is a lot. And then I coaxed him to walk, and he could walk. And I was looking at his feet. His feet were clearing the ground. So what does that also tell you? He wasn't dragging his foot. He was clearing the ground. He was shuffling slowly. What does that tell you? L4, L5's working because he doesn't have a foot drag. He doesn't have a drop foot. So he's basically functioning, but he wouldn't walk by himself. But then when I let him go in the hallway, he started walking by himself. So that's basically the physical exam. He had no clonus, reflexes were 0. So what would you say? Is he paralyzed?
No.
No, right? So what would you think? What would you describe? How would you think? What's going through your mind at this point after the physical exam? In the story, history and physical. Otherwise, he's a healthy man, 60 years old with Down syndrome.
It must be painful to walk, which is why he would have stopped.
Okay, it could be painful, but he wasn't on exam. He wasn't groaning, and he wasn't. So what else? If it's not painful, what else? What other reasons why could you just think? How about your kids? Sometimes when they won't do something, why?
They don't want to.
They don't want to, or maybe he's afraid. That's the other thing I was thinking. So he's developed. I think this is my personal theory. He's got cervical ataxia, maybe. He's just afraid to walk because his balance is off. So just like a child, they're afraid they won't do something. But if you coax them, get them to walk, then they start walking. So maybe he's just afraid because something's not right in his body, and he's tending to fall, and his balance is off. So, you buy that?
Mm-hmm.
So that's sort of what was going on in my mind on exam. So anyone think any other questions you want to ask about this man? You don't have to have questions. So what do you think of the X-rays? Go. You're going to say something, Megan? Go ahead.
Has he fallen recently? Before he stopped
No
manipulating?
history of falls.
No history of falls.
Mm-mm. No, that's a good question. No, he hasn't fallen. So what do you think, Aaron, of the X-ray? This is not a trick question. Can you see anything? No, it's really hard, right? You can see that there's bones. You can see a mandible. And think about the X-ray tech trying to get an X-ray on this guy. Hold still. He's not going to hold still. It's like a baby, so it's really hard to get an X-ray on somebody like him. So at least on the side view, on the lateral view, you can see the mandible. You can see C2 here, C1 and C2, 3, 4, 5. On the AP film, his cervical spine on the front view is just a little bit crooked, a little bit scoliotic. So do you want to? So he's got Down syndrome. So what is Down syndrome? Do you want to say anything that you know, or you want me to just keep talking?
Just a genetic.
It's a genetic abnormality. So I'm not an expert, but I just read about it last night. Okay, so it's trisomy 21. So it's the most common chromosomal abnormality that we know of. These are all the features. So quite often it presents after birth. Sometimes not. I remember my wife, she was an older gal when she had her children, and she was tested. She'd kill me if she knew I said that. And she had the needle and the amniocentesis, to see if it was Downs, and but quite often they just present as a baby. So that's why you have to know what the children look like. They commonly have growth failure, and usually they don't grow much. Men don't grow much past 5'1", and women don't grow much past 4'9". So they're small statured. They have mental retardation, and the average, to be an average, intelligence, we measure it with the IQ test. It's just a test that we made up to see kind of how people do with skills and things. And the main problem is if you don't do well on the IQ test, if you don't get over 70, you have a problem with daily life when you get a problem. Let's say your water heater breaks. If you're mentally retarded, you just have a real hard time dealing with that problem. You can't look it up in the yellow pages, call a friend, see how much it costs, look up how much you just can't go through problems. So life's very difficult. But if your life is very easy, those people do fine. But it's when a problem occurs that they just can't overcome problems. So 70 sort of is basically our human-made cutoff. with this test for whatever, some people say the test is worthless, but it's what we have to kind of understand intelligence. So usually Down syndrome is around 50 to 70 in IQ testing, so they can't function by themselves really, but some can, and but it can be lower too, 30 to 50. So our man is obviously, he's not even on the scale. I mean, he can't even talk, so he's more like a baby. So they have mental retardation. The back of their head is flat. They have normal ears. Their fingertips have loops. They have extra creases. They have a crease in their palm that goes all the way across their hand. They have intestinal issues. Sometimes there's large bowel does not have innervation, and they have constipation, so their colon doesn't move basically, and they have what's called Hirschsprung's disease, and they're just constantly chronically constipated. They have hernias. Some are born without an anus. They have congenital heart disease, like defects in the ventricle or atrium. Their toes are spaced apart, so they have collagen abnormalities too. So the connective tissue of their bodies is defective, and that also happens. You can see the abnormalities in the fingers, but also it happens in the spine. We're going to get into that. What kind of spinal problems they have. They have short, broad hands, and their basic abnormality is they have an extra chromosome. So chromosome 21, they have 3 instead of 2, and that's a major problem. So anything you want to add about? The other thing, their eyes, they have, the most important feature, they have slanting eyes, and they're very distinctive appearance of their eyes and face, and a broad, flat face. So they have a flat face, flat bridge of the nose, and like a distinctive eyes, like slanting sort of eyes. So why do we call it Downs? Well, because this man, John Langdon Down, first described it. So Down syndrome occurs in 1 in 691 babies, and Down was a medical doctor in London, and he decided, he was like a very promising doctor, a surgeon too. He decided to spend his life taking care of these people. So back then they called it idiocy, which is, so what happens is any kind of term that describes mental deficiency becomes slang, and we use it against each other. It becomes a mean word, so nobody uses the word idiocy anymore, but that used to be the word. And he used to, he took care of like a whole hospital, and that was sort of his life work. And then, interestingly, his sons did the same thing, became doctors and took care of these people. And he first described a certain type of person that has a mental deficiency, that all the kids looked similar, and he called it Mongolism, because he felt they looked like people from Mongolia. So for a long time it was called Mongolism. Boring. So why do older gals get tested? Because the incidence of Down syndrome increases precipitously as you start to reach 40. So I think it's like 35 it starts to increase.
That's correct.
35?
After 35 they'll do testing.
They start testing, yeah. So, but then it's like really at 40 that it really starts to elevate. So what spinal problems do people with Downs get? They usually get C1, C2 instability.
Kind of like rheumatoid kind of.
Yeah. You could think of it that way. So the rheumatoid patients get the same thing. Rheumatoid's a little different because they also get pannus, but they also get C1, C2 instability. You're right. So C1, when it flexes forward, it should normally, in the neck, it should normally just flex forward a little bit, but like we said, C1, C2, if it flexes a lot, the spinal cord can get compressed here. And what happens is the patient can become totally paralyzed from this type of problem or injury. So there was an article in the Journal of Bone and Joint Surgery where they reviewed, I think it was like 100 children in a group home or institution to see the incidence of C1, C2 instability, because one child all of a sudden became quadriplegic, like all of a sudden couldn't move anything. They're like, well, what happened? and they looked into it and they found that the child had C1, C2 instability. So then they tested all the children and they saw that a lot of them did have C1, C2 instability when they flexed forward, like 20% or something. But not all of them were symptomatic. And this instability is the facets. The facets aren't working. So you look at, if you look at the model, here's the model. Well, actually we can just, if you look at the model, so what is keeping you, Aaron, what do you think? I'm gonna ask you, put you on the spot. What do you think keeps you from going like that, like C1 going forwards on C2? What structures? There's 3 of them. So what's the check rein? What keeps the C1, C2 from flexing forwards? There's 3 things. Yep, the transverse ligament that goes across the dens, behind the dens, and then the facets, and the 2 facets. So those things are made out of collagen. So if they're loose, the C1 can go forwards on C2. So here's a case of instability. Here's the extended view, and here's C1, and here's the dens. You see that? And back here is where the spinal cord runs. So this person, when they flex forwards, here's C2, here's C1. See how the arch of C1 is way forward to C2? And from here to here, that's all the area that's left for the spinal cord. We call that SAC, or space available for the spinal cord. The spinal cord gets severely compressed here. See how small that area is? On this view, you can see the area goes from here to here. It's not working up there? Oh, shoot. Hold on.
I'll come over.
No. I'll move it. Hold on. Oh, I see what I did. I'll switch it. Yeah, you want to just come over here? I took a shower today. Right here. So the space available for the cord is from here to here. So that's much bigger than here to here where there's instability. See that? Mm-hmm. So that's where the spinal cord gets compressed. Here's C1, arch of C1, and here's C2. And here's the arch of C1 and C2. I see how C1 is way forward to C2. It's hard for you to see it because it's just not clear on the X-ray. But you can see there that the spinal cord would be compressed right in there. So we have back with our guy now. So here's, let's just go over ataxia. We went over this last week, but in ataxic and a spastic gait, quite often they scissor. This guy does not scissor actually, and quite often they're bent forward. And the description for a child with ataxia is they walk with their feet wide apart, and that makes sense because it's like a stable base. Because if you have a narrow, like in wrestling or any sport, they always say keep your feet separated, because if someone hits you and your feet are together, you'll fall down immediately. So the children figure this out too. So they make their feet wide apart, and they go very slowly, like on a rough sea or someone who's drunk. And that's how this man walks too.
Short gait.
Short stride.
So that they don't lift their feet up off the ground.
Yeah.
Because they don't want to be in single leg stance.
Yeah, short stride. Right? Mm-hmm. And slow cadence, very slow usually. Okay. So here's the obliques. What do you think of the obliques, Aaron?
Much better than the AP and lateral one.
Yeah, the quality's not so good, but you can see actually a couple things are kind of interesting. You can see the foramina, like right here. You can see the facet here, so you can see the pedicle. That's a really nice view of a cervical pedicle, and the foramen and the pedicle, and the facet. And you see how the superior articular facet below goes into the foramen. So we don't do a lot of foraminotomies, but that's what we remove mostly, the superior articulating facet. So if you look at the model, here's the foramen right there, the hole, and you see how usually the offending is the supraarticulating facet. You see the one from below. So when we do our frame anatomies, we do them from the backside. We make a hole right there, and we open it up, and then we're opening up that hole. And we know if we go from pedicle to pedicle, that's why, and quite often in surgery, I was like, is this the pedicle? Because the pedicle kind of like defines the space, so we know where we are. But he doesn't have much in the way of uncle osteophytes, does he? Remember in the office, we would say, wow, that's a big uncle osteophyte. He has no uncle osteophytes. That's kind of interesting, right?
That's interesting.
Okay. So if you go through the ER, everybody gets a CAT scan, right? And why do you think that is? Fast and cheap. Yeah. So it's a fast, cheap test that gives you a lot of information. So everybody gets a CAT scan. So his CAT scan is really interesting. Let me show you a couple of interesting things. Here's C2, and here is C1. So is C1 really far away from C2, or is it close to it? Or
It's close.
It's close, right? So it doesn't seem that he has C1, C2 instability. How about the C2, C3 disc? Does it look normal?
Flat.
Dramatically decreased, right? How about C3, C4?
Same.
Dramatically decreased, right? Now, a couple interesting things is that he has some element of rotatory subluxation of C1, C2. So this is hard to know, but this is the occiput right here, and this is the C1 atlas. And see how C1 and C2 don't line up just right?
Mm-hmm.
But we know C1, C2 is not subluxated anteriorly, but it's off a little bit, so it has to be subluxated a little bit to look like that. Same thing here. See how from here to here it does not line up completely from here to here? So C1, C2 is rotating a little bit, isn't it? I'll show you why I'm sure about it. How about C2, C3 facet? Kind of arthritic, right?
Mm-hmm.
C3, C4 is arthritic. How about C4, C5 facet? How about C5, C6 facet? What does it look like?
Pretty bad.
Looks even fused, doesn't it? It's kind of weird, right? Doesn't this look kind of fused?
Mm-hmm.
So he looks a little bit auto-fused, doesn't he? Kind of weird, like kind of rheumatoid. Remember? You said it's kind of like rheumatoid. It's similar, isn't it? So here are the axial cuts. Here's C1, and the C1 vertebral body atlas is kind of like, looks like it's this alignment. Here's C2. Here's the ligament that keeps it from going forwards. And then C2 is angled like this. So they're rotated. You see how they're rotated? They're not. And I'll show you a perfect what it should look like. It should look like this. It should be straight, and this one should be totally straight too, although it's hard to see. But it's rotated like that. Can you see how that would rotate? Now we do have normal rotation. Like that's normal to rotate at that level. In fact,
It's like 50%, isn't it?
yeah, it's a lot of our rotation. So for this guy, how much rotation? Remember we said the other ones are fused?
He should have about.
It's probably all of his rotation comes from there, right?
Yeah.
So him subluxating, I mean, kind of makes sense, right? Because that's how he turns his head now. Because the rest of his spine, like you said, is a little bit rheumatoid-like, and it's fusing. Everything comes from the top.
Right.
So it should be quite natural that he's rotating a lot. The other thing is that why does he have two lamina? A little bit like a trick question. Why is there two lamina here at C3, C4 in the axial cut? It's because the bones are subluxating and they're next to each other. And I'll show you what I mean by that, okay? So this is C1, C2, and this is C3, and then you can see a little bit of C4 as well. It's kind of weird. Okay, so this should look like, and that shows you how it's rotated. So now this is atlantoaxial rotatory instability. That's a condition that happens in kids. Have you guys heard about it? Some kids get this, and it's a viral condition where for some reason the virus attacks the kids get viruses all the time in their face and throats, but sometimes the same virus attacks the joint at C1, C2, and they get this like really painful neck that's rotated and like torticollis. It's really, have you ever seen it?
Mm-mm.
Really scary. And sometimes it just goes away. But sometimes it can become like a serious problem where the child's neck is stiff and curved a lot. So, I remember when we were at Hopkins, we put traction on it to try to get it straighter, and maybe it'll just go away. But if it's a bad case of it, sometimes these kids need a C1, C2 fusion. Needs to be reduced and fused, yeah. But this is not what this guy has. So just a couple more ideas. Is you see how the facet of occiput, C1, C2, they should all line up like that. And this just shows you these are the condyles that go to the head, and C2, and the ligament that goes, the transverse ligament that goes across here that keeps C1, C2 like together. And this is what it should look like. Remember, occiput, C1, and C2. See how normally it should looks like? And look at his. See how it's off? See how it's off right there? And it should look like that. It should totally line up. So, and also the other thing is vertebral body and lamina. See how the top of the vertebral body is a little bit higher than lamina? So I'll show you some. And here's what the facets should look like. There should be a black line going across every facet, which is the joint. But look at his facets. See how they're all autofused? So, like you said, you're right. He's a little bit like a rheumatoid spine, isn't he? So that's just not so helpful. So here's his MRI. So he came to the hospital. You said a CAT scan. I was like, well, we got to get an MRI to see what's going on. So here's his MRI.
How did you keep him still for the MRI?
I didn't do anything. It just, I didn't even think about it. He just sat still.
Because it's good.
Yeah, it is good. Yeah, I didn't even think about that. I guess, just lucky. He, maybe they just gave him a pillow and he fell asleep. I don't know. The MRI scanning techs, they're pretty, if you start moving, they start getting angry, and maybe they like screamed out, "Sit still," or something. Maybe he was scared. Anyway, it worked. So here's his MRI. So what do you think is the biggest problem, Aaron? Right? Can you see right off the bat? You may want to look up top, because I have to do this so that I have to bend the screen.
Right. It's
severe spinal cord compression,
Great.
right? Right here at the very top. Does he have any problems up at at C1, C2 in the spinal canal?
no. Well, no. He's
Not
got a
really,
large
right?
Area posterior.
He's got a really large area back there, doesn't he? So he's severely compressed right here. So you should probably look here so I can show you.
I can see it bent forward. It's fine.
Can you see it bent forward?
Mm-hmm.
Hold on, because it has to be like that. Can you guys see that?
Mm-hmm.
Okay. So he's severely compressed here, isn't he? Like terrible. And initially I wasn't sure what level that was, but that's at C3, C4. So let me show you something. This is the arch of C1. This is the posterior element of C2. This is the lamina of C3, which is kind of a weird place. And this is the lamina of C4. And the reason why they're off is because everything's subluxated. See how this point here is behind this point here? So C2 is posterior to C3. And this point here, C3, is way posterior to this point here at C4, isn't it? And he's all autofused here, C4, C5, C5, C6. He should have discs across all those levels. So he's got a lot of retrolisthesis, and because of that, he's compressing his spinal cord, probably as a result of this retrolisthesis. His vertebrae are not lining up. So here's the axial cuts. Spinal cord at C1, you can see the atlas of C1, C2, C2, C3. The spinal cord is not too bad. And C3, C4, you see how it's severely compressed. And this is the lamina of C3, and this thing is the lamina of C4. See that?
Mm-hmm.
And when I measured it, it was 7 millimeters. And you see how the spinal cord is deformed here at C3, C4. The spinal cord should look like this normally. So he has severe compression at C3, C4. And this shows you now you can see how the CAT scan shows the lamina a lot better than the MRI scan. You see, so this C2 and C2, that makes sense, right? C1, C1, that makes sense. C3 and C3, see how it lines up now? C4 and C4. See that?
Mm-hmm.
So now you agree with me, right? I'm not crazy. That this is really his culprit. C4 is really compressing his spinal cord. Right there, this is C4. One more time so you understand it. C2, C3, C4, they're all shingled against each other due to the deformity. And it's compressing his spinal cord right there. Okay, so that's it. So now what do we do?
It's really interesting.
Yeah. So assessment. What's his chief complaint, you think? What's his main problem?
Ataxia.
Ataxia. Yeah, ataxia is his chief complaint. So what about this guy? Like, do you know what the average age is? Lifespan for Downs? You see a lot of. It's like they don't live much past 60. So
it is.
Yeah. So he's very. It used to be really young, but take care of these people. They live a long time, but they don't live. So he's a very elderly man for Down syndrome. So that just tells you his activity level, is very minimum. So what are the risks of? What's the treatment for cervical stenosis?
Surgical.
Decompression. Yeah, it's only a surgical treatment. So you can it's not an emergency, but it's a surgical treatment. So in this man, basically we didn't have guardianship, so legally, really, like I really couldn't do anything. I couldn't get consent, and he had no guardian, he had no family, nothing. So we couldn't do anything. So he just sat in the hospital because there's nothing we could do for him. We couldn't send him home, and we also couldn't send him to a nursing home because to go to a nursing home you need guardianship. Someone has to consent. So we had to wait. So I called the sheriff's office. They're closed. So I was like, then I told the social worker, you got to help me with this. So then the social worker called the back line, and they had to get a judge's order to assign a man at Harford County Social Services to be that guardian. And we just got that, and it took 10 days to go through the process. So now we have a guardian, and now we got a plan, so we can do surgery in a week. We set a date, and the guardian agreed to send them to rehab. So we can do the surgery now legally. So what are the risks of any type of surgery? Like, what's the risks of cervical surgery?
Well, paralysis because you're at the level of the spinal cord.
Yeah. So we can make him worse, but he's not doing so well now either, right?
Well.
And it's a problem if you can't walk. I mean, he probably won't be as happy, I would think, because it's fun to walk. I mean, he enjoys walking. You see him he walks around, looks around. So it's a big quality of life to be able to walk. But also it's a lot more care because someone has to walk him. It's like, so it's probably worth the money for the state to fix his spine,
Mm-hmm.
And also, like, what's fair is, like, as a human being, like, have some compassion. Like, this person, can be helped with the surgery. So, what levels to decompress? What levels to fuse?
3, 4.
So definitely decompress 3, 4, and 2, 3 was a little bit stenotic, right? And then should we fuse those levels? What are the risks, benefits of fusing those levels too?
Well, that's where all of his motion is, since he's auto-fused lower, so we're taking away
some level of motion, but I'm not sure how much motion occurs at C2, look how athletic those discs are. I'm not sure how much motion happens at C2, C3, C3, C4, but I would think a lot of motion does happen at occiput C1 and C1, C2. So the other thing is if we fuse C2, C3, C3, C4, C4, C5, puts more stress on C1, C2, occiput C1, C2, and he may develop what? Instability, right? He may develop the instability that Down's patients get. So that's a risk too. So what can we do to stop all instability? C1, C2, occiput C1, C2, C3. What can we do to stop all the instability? Fuse the whole thing. Like, remember last month we fused occiput to C5, so we can do that for him. But now we're talking a much bigger surgery for this man, who, like, remember we said he's a very elderly man for his lifespan, So we also want to cause a death, right? Because we want to first do no harm. So those are kind of like all the things I think that are going through my mind what to do for this guy. Do you have any comments or questions about options? So there's the level. So, and then the timing, like we said, and instrumentation adds one more element to the case. So any other questions or comments? I'll tell you what my final thoughts are. I haven't done the surgery yet.
don't know. I would say keeping. I would risk probably the instability at
C1, C2.
at the occiput C1 to give him some sort of quality of life, and he's
Quality of life in the sense of like motion, so his neck can move and he can look around. Because he does do that. He cruises.
And if
And he doesn't have any gross instability that can be conceived, that it can be proved right now. Although it does subluxate a little bit on the CAT scan, doesn't it? Okay, so Megan said don't fuse C1, C2.
I would agree with her. I mean, he doesn't have much else. That's, if you equated him like a 1-year-old in the beginning, that's...
Yeah, I think those are my thoughts as well. So I don't think I should fuse C1, C2. Let him have that motion. We're taking that risk, but everything comes with risk sometimes. I don't think it's a great risk. And then decompress half of C. So I was going to decompress half of C2. And remember, the reason why I try to keep C2 intact is because a lot of the extensor musculature is attached right here.
Mm-hmm.
A lot of it to keep your head up. So we just cut half of that, take all of C3 off, all of C4 off, and maybe just a tiny bit of 5 to fully decompress the spinal cord, and then just fuse those levels without instrumentation. Just pack bone graft into the facet areas. We can use lamina. I haven't thought about iliac crest.
compliance afterwards, though. Well, I mean, I think
Compliant. We can't count on any compliance on him.
right. So I mean,
He's like a baby. He's like a child. He's
well,
going to start
I'm
walking right
saying
away.
that, why not do instrumentation? I'm just asking.
You can ask questions. We can. I can do instrumentation. I guess it will increase the fusion rate for him. It's also increases the infection rate for him. Usually cervical spine fuses. He already has been shown to be predisposed to fuse. He fused it without surgery.
Mm-hmm.
Usually cervical spines don't get non-unions. The other thing is, I think even if he does not fuse, I think it's very unlikely that those levels will become unstable, because look at C2, C3. Like there's almost no area. There's no area at all for the disc space at all. It looks like it's going on the autofusion anyway.
Mm-hmm.
So why make the surgery more complicated to increase fusion rate when we don't think he's? I don't think he's going to get unstable at those levels, even if I just did a laminectomy, because there's not much in the way of a disc space. Does that make sense? So if you have like a large disc space, normal facets, and then decompress, those patients are a lot more likely to become unstable. You see, so that they would benefit from a fusion.
Now, typically after your fusions, you allow them to move. Am I correct?
Yeah, usually people do whatever they want.
Right. That's what I thought. I know there's other physicians that don't.
Yeah, keep people down or keep them
Or keep
restricted
them
and
in
embrace.
collars, but
collar.
I'm right by saying that.
Yeah.
Okay.
Yeah, I don't think it makes a difference. And I like people just to go back to their lives. I don't like restricting people a lot. I don't think it helps. So I think that the risks of fusing those levels is minimal. We just burr out the facets and pack bone in it. It's not that much more surgery. It doesn't take that long. It'll slightly decrease the risks of instability. I think if you start adding instrumentation, it increases the infection risk. I don't want to get this guy get infected. I really don't want to have to do another surgery on him.
And couldn't you use the lamina for the bone graft?
Yeah, I could use
instead of
lamina for
doing
bone.
the iliac?
Yeah, I was probably going to do that. Use lamina, local bone graft for him, because he'll probably go on the fuse anyway easily, because he has a tendency to fuse. And also, the disc spaces are almost gone, so there's almost probably very limited motion at that level anyway. So those are my thoughts. Why not to use instrumentation? Does that make sense? All right. So any other questions about this case? It just shows the laminectomies that we're going to do troughs. Our standard thing, Aaron, troughs on either side, and then finish it and pull the bone off, and then drill the facets out and pack the bone into the facets. That's my backyard last night. So any questions about Down syndrome? Let's finish it up. One thing we all learned about from today's conference. I'll start. I learned that. What did I learn? Actually, I learned that when you get retrolisthesis and loss of the disc height, you can really compress the spinal cord from the lamina. I was really surprised at the levels. And if I hadn't carefully looked at that, you can easily decompress the wrong levels. I mean, I already knew this rule anyway, but preoperatively, you have to really understand the anatomy, because if you don't, you'll do the wrong surgery very easily. And in complicated cases, it's really important to do things like this. So I learned a lot from him. Okay, Megan, your next one thing you learn. You gotta learn at least one thing.
I just didn't realize how unstable Down syndrome spines could be.
Yeah.
Like, really and that makes me think of back to some Down's patients that I've had.
You've had some Down patients. They can have C1, C2 instability. But even if they have it, it may not be symptomatic. Like,
right.
But it's there.
But, with manual work that we do, that can be a little scary.
Okay, great. Aaron, you're last.
Kind of like what Megan said, it's interesting that you hear, when you learn the basics about Downs and the hands and the feet, and you think of these physical characteristics, you don't necessarily think about how it affects more serious structures in the cervical spine.
Organs.
And then, actually, I liked seeing the MRI and the CT next to
juxtaposed,
each other.
right? Yeah.
And it's like I can probably learn a lot more if I just take time and start looking at things.
But you never get
side by
that,
side.
That's why
Right.
it's only in cases like this
But-
that you get that. It's
But
interesting.
sometimes when we look at non-union, we might have a CT and an MRI
Yeah.
that we can evaluate. And in this case, it's necessary, but just in general, I think there's a lot more I can learn by looking at those two studies side by side.
Yeah, it's really helpful to have both. Yeah, I agree. Okay, great. See you next month.